We're recording. Sweet. All righty. Is everybody here? Oh, there we go. Participants. Hi there, everybody. It looks like we have 20 participants, so I think we're going to get started. I'm going to share my screen really quickly here. Trippy, but can you guys see my screen? John, can
Yes,
you see it?
sir.
All right. So I'm going to get started, and John and I will introduce ourselves. My name is Greg Pereira. I'm a chief resident orthopedic surgery. John, you want to give a little intro?
Sure. I'm John Kodosky. I'm an ortho trauma physician assistant in San Antonio at a level 1 trauma center, and I'm the medical science liaison for Arbutus Medical.
Awesome. Well, it's great to have all you guys today. So we're going to be talking today about simplifying skeletal traction and some products, obviously, from Arbutus Medical. So for our disclosures, both John and I are only disclosures that we consult with Arbutus Medical, and we've been kind of helping them develop their product line, which we'll talk about today. So diving right in, and by the way, please put your questions in the chat if you have any, and John, stop me at any point, or anybody can really stop me if you have questions, because we want to make this as interactive as possible. But we think about goals of skeletal traction. So, what are the goals? Well, the first, interestingly, is to decrease blood loss. If you remember with long bones, they have the hematopoietic stem cells and kind of high vascularity in that medullary canal. So, when you break a long bone, like the femur seen to the right side of the screen, there's a lot of blood loss and there's a lot of bleeding. So, by actually putting skeletal traction or pulling skeletal traction through the leg, you can create a tamponading effect, which actually decreases blood loss. And with that, also in this image, you can see these sharp bony spikes. Those bony spikes are going to be sitting in the surrounding musculature. So to the second point, if you actually pull those bony spikes into a more anatomic location, you can decrease the pain and spasm associated with those muscular spikes kind of resting in the soft tissues. The third point, to distract the joint, occurs actually more for, when you think of like acetabular fractures or any fracture with an incarcerated fragment in the joint. The incarcerated fragment can grind that chondral surface. So by distracting across the joint, it temporizes you till surgery till you can actually kind of remove that incarcerated fragment. So we kind of hit on some of the common indications here. The most common of which, for me at least, is shortened femoral shaft fractures. Again, the shortening forces, you'll frequently see the image on the right of the screen, and skeletal traction helps pull them to length. Another common thing you'll see in high energy trauma is an unstable acetabular fracture dislocation. So something like the image on the top of the screen there with a large posterior wall fragment. These are the stable acetabular fractures that you can do the reduction, so you can reduce the hip and then it just falls right back out. So skeletal traction in this case may hold the joint reduced, and that obviously can be very helpful. To the third point in that image, you can also see this was a acetabular fracture dislocation with a large incarcerated fragment. After you get a CT scan, when you're seeing these high energy traumas and you see that incarcerated fragment, that can be an indication in itself after you reduce the joint to use skeletal traction. And the fourth, actually, for boards, for OITE, etc., is the vertical shear pelvis fracture pattern, which is a rare injury. It's a high energy injury. It's scary to see, but this is a board question. What do you do when you see it? Similar to how with APC pelvis fractures and open moving pelvises, you put a pelvic binder. In vertical shear patterns, you use skeletal traction to help kind of reduce and pull that hemipelvis down. So diving into the actual logistics, femoral traction is what I do most commonly at my institution, and we'll walk you through tibial traction as well. But I've kind of simplified this for you into 7 steps. So each of these steps, and this is kind of redundant with tibial traction, as you'll see, is just something to make things flow smoothly and to make the patient more comfortable. So the first thing to do is to set up the itemized materials in the room, and we'll go through the other 6 steps thereafter. So, in my institution, the materials kind of came from 3 places. So, the traction bed is something you'll absolutely need. You'll move them from the regular gurney to a traction bed. The actual driver in this case, StereoTrack is, something you can kind of have a grab and go feature and go directly to actually drive the pin. And, in my institution, before we had the skeletal traction procedure kit, you had to get all the necessary items to actually numb the patient's leg, drive the pin, and then actually dress the pin. But now with the skeletal traction procedure kit seen here, you truly just grab your pin driver, you grab your skeletal traction procedure kit, and you're ready to actually perform the procedure, which is pretty nice. The only thing that's not included in this is a Kirschner bow, which again, based on your institution, is something you'll need to grab to actually complete the procedure. So after you get the room set up, you want to make sure for femoral traction in particular, you bump and derotate the leg. Remember that a lot of times these patients have, kind of the classic shortened and externally rotated leg that you'll see kind of in the image on the right. And you want to make sure that you derotate the leg so that when you drive the pin from medial to lateral, you're able to actually see it exit. You're able to see the pin exit and you're not drilling into the gurney. So by bumping and derotating the leg, you're really just going to set yourself up for success. And that's, again, something that's easily glossed over when you're first starting. So if you just tell yourself that you need to see both the medial and lateral side, it's going to really help you.
And one of the things you'll hear me say throughout this is act like you're in the OR. Everybody takes so much time to get set up and organized and mark their landmarks, but they don't do it outside of that OR. Remember, whenever you're not in the operating room, that doesn't change how you set up for your procedures. So make sure you act accordingly and get yourself set up.
Yeah, that's a great point. And I think one of the things we always talk about is people being like fast and efficient. And I don't think anybody ever really moves their hands faster. It's just you don't want to have to repeat steps. So to John's point there, set up the room, think about it like you're in the OR. In the OR, you don't want to repeat steps. In this case, you don't want to take 2 steps back to, let's say, to derotate the leg after you've set everything up, because then you might need to take off your sterile gloves, put on new gloves, etc. So trying to be really organized is really going to help you. So that's a great point, John. So the following step will be landmarks. I always mark the joint line because you want your pin to be parallel to the joint line. The next thing I do is I mark the superior pole of the patella. Some people in the image, as you'll see there, will actually mark the whole patella. That's individual preference. And I like to mark the tubercle just because that gives me a good understanding of like where the tibia is and kind of the axis of the tibia. But the real important thing here is to march your finger 2 to 3 or to mark out 2 to 3 centimeters proximal to the superior pole. The reason being is if you remember anatomically, the capsule actually extends quite proximally. And when you're actually putting the pin in, if you fall anterior, you don't want to create a traumatic arthrotomy. So that level, 2 to 3 centimeters proximal to the superior pole, is exactly kind of the level at which your pin will be driven through the bone. So the next thing you're going to do is you're going to inject lidocaine. Now, I think when you inject the lidocaine, you want to inject the soft tissues, and you want to do it both medially and laterally based on where you think you're going to place your pin. But one thing that's also important is to remember that the periosteum has a high concentration of of nerves. So and that's also going to be the site where the pin interfaces with the bone, and that's where there's heat generation. That's going to be where a lot of the pain comes from. So putting a lot of lidocaine at the periosteal interface right at the site of where you're going to place your pin is really going to increase patient comfort.
The other thing to remember too, be patient. Be patient. Lidocaine takes at least 1 to 2 minutes to start. So you need to make sure that you do your injection, wait for that anesthesia to kick in. The last thing you want to do is try and hit that injection and then try and put the pin in right after. The patient's going to feel a lot of pain.
Yeah, that's a great point. It's something I think we frequently forget in orthopedics. So wait the 2 minutes. That's an excellent point. So the next thing you're going to do is you're going to actually get ready to drive the pin. Whenever you're placing a traction pin, you want to think of the structures that you're most likely to injure, or the scary things. So with the femur, you're thinking about the femoral bundle, and that's why you want to start on the medial side because you have the most control. So you place your pin again on the medial side, and you try to be kind of centered in the bone. But that being said, once the pin hits the bone, you're going to march anteriorly until you kind of fall off the bone on the front, march posteriorly, fall off the bone in the back, and then in your mind's eye, you're going to try to be kind of in the center to anterior third of the bone and drive the pin. Once you've driven the pin, you're going to want to dress the pin, and to do so, you can use all the things in the skeletal traction procedure kit. And along with the actual kit or the bag that Arbutus has, you'll see wire cutters so that you can cut kind of the blue inserter or the interface, which you'll see on the actual device. So you just cut that off with the wire cutters.
We did have a question in the chat. How much lidocaine do you use? Greg and I agree. We're at about 20. I'll do maybe 1 to 2 for a skin wheel, dump the other 8 to 9 on the periosteum, on the medial, and then the lateral side where I expect the pin to come out.
Yeah, that's a great point, because a lot of times when you ask for lidocaine in the ER, they'll give you 5 cc's, and make sure, you kind of you tell the nurses if they do that, you need more. And that's an excellent point because, I mean, this is a kind of it's a scary procedure for a patient, probably the only time in their life they'll have it. And, you want to get them as comfortable as they can be. It's a great question. The last step is the cabo and the traction pin. The cabo is a tensioning device. It helps, with the 2 millimeter pins to tension it so that you can pull more weight through it without actually bending it. So you put that on, and then you obviously connect that cabo to a rope, which is attached to the traction bed, the kind of pulley system that you can kind of see right up here. Your goal is really just to pull longitudinal traction in line with the long axis of the limb. So that's that. So just as a poll here, and I'll defer to Nancy and the folks who are running this webinar, who does skeletal traction at, or which of you guys do skeletal traction at your institution? Give it a minute.
How many cases of skeletal traction does your hospital do in a week?
Oh yeah, that's a great question.
Mm-hmm. Getting mostly 5+. So we got some busy centers here. That's for sure.
That's great.
While we're doing
Yeah.
this, I know a couple of our new interns are on this, so I'll talk to the interns that are in San Antonio about to start here on Friday. For us, the hardest part is finding all the stuff. So we're going to grab our bed setup out of a locked closet, and we're going to grab our drill out of our workroom, and the bows are in our workroom, and everything else is next to the patient. So I know, Greg, you're similar in how you have to do everything too. So
totally. Yep. That skeletal traction procedure kit was kind of the godsend, because the first time you do these things, you inevitably forget something, and you have to do trips in and out of the room, and you look inefficient, and you look, maybe nervous, and it doesn't really inspire confidence in, the patients, and it slows down your efficiency. So I think that is really a very nice feature, and something that we really benefited from at our center. So I think we've given that a good amount of time, and keep polling if you need to, but we will move to tibial traction, which is another very common form of skeletal traction. So similarly here, I have 7 steps, and the first 2 are the same. So setting up your itemized materials in the room is going to really inspire confidence for your patient. It's going to increase your efficiency. It's going to save you trips in and out of the room, which I think are really big time savers overall. Derotating the leg and making sure you can see the lateral and medial aspect of where your pin is going to come through, always an important thing. So those 2 steps remain the exact same. The landmarks here are a little bit different though. So you still mark the joint line, because you want to always be parallel to that joint line. You don't want to be pulling kind of an obliquity to it. The superior pull of the patella, or the patella in general, I think is nice to do, but it's not mission critical here. The more important thing here is the tibial tubercle, because the tubercle is what you're going to measure from. So you measure 2 to 3 centimeters distal and inferior to, like distal, or I guess, sorry, it should be distal and posterior or lateral to the tubercle. So you can kind of see here, if on this image, I typically just go based on my finger breaths. You can measure your fingers, which is really helpful in the OR too, and know the distance. But 2 finger breaths kind of lateral towards kind of the fibula, and then 2 finger breaths distal. But that's my entry point. The next point is lidocaine, which to John's point previously is you want to use lidocaine and you want to give it time to work. So you're going to do both the lateral and medial side, where you think the pin is going to enter and exit, and then wait 2 minutes. After that, again, you can see here the tubercle is marked in about a circle. We're 2 centimeters lateral, 2 centimeters distal. So that's the start point. And you're driving here. So remember, what is the structure you're worried about? In this case, on the tibial side, you're worried about the common perineal nerve wrapping around the fibular neck. So you're going to want to start on the lateral side. So it's the opposite of tibial traction in that regard, or sorry, femoral traction in that regard. So drive that pin from lateral to medial. And after that, it's the exact same final two steps. You dress the pin the same way you would for a femoral pin, and then you use the Kirschner bow to tension it, and then you attach it to the traction bed and add your weights. So
I'd like
calcaneal
to
tract.
add.
Oh,
I'd
go
like
ahead.
to add
Sorry.
one quick thing on the tibia, if you wouldn't mind going back one slide there for me, Greg. I'd
Yep.
appreciate that, sir. So the tibia, I have a little model here, is very triangular. So whenever we're coming in on this and we're coming lateral, we want to make sure that we get perpendicular to the bone to create a burr, and then we drop our hand and shoot right across. If we just try and shoot right across, and I'll show you this in the demonstration, it'll try and walk up the side of the tibia and we'll skive off the top, or we'll get a unicortical pin. So we want to make sure we get that little burr going, and I'll show you how to do that in just a second.
Yeah, that's a great point. That's a great skill to learn because whenever you put, X fixes on delta frames or knee spanning X fixes, you're actually going to be on the opposite side. You'll be on the kind of the medial side, which is even a more acute angle on the tibia. And learning that trick of how to kind of create a burr and then dropping your hand appropriately to stay parallel, or sorry, perpendicular in this case to the bone is a trick you'll use in the O-arm. So that's awesome. John, actually, so for calcaneal traction, that's something that is a lot less commonly used. I actually never
Yeah.
use it at our center. But that being said, I know you guys have done it more than I have, so maybe you can give some pearls, or you want to walk them through this.
Sure. And when you say that we've done it more than you, in the 15 plus years I've worked as orthopedics, I can recall of doing 3. So at an average of 1 every 5 years, with the last one being last week, as a matter of fact. So calcaneal traction, it's an option, but it is extremely rare and it's not often used, primarily because the indications of it are very specific. We need to have the patient who needs skeletal traction but has some sort of skin compromise at the distal femur or the proximal tibia, but the knee joint is still intact, the femoral neck is still intact, and the tibia and ankle are still intact. So that's a very, very specific patient that's going to be capable of receiving skeletal traction or requiring a skeletal traction through the calcaneus. It really, the quick version of this is we put it in exactly like we're doing an external fixator, a delta frame on the ankle. And really, we're going to find the medial malleolus. We're going to make sure that we avoid the neurovascular bundle and go right through the heart of the calcaneus. And we're going to go medial to lateral. And we're going to apply the pin. We're going to do all of our anesthesia the exact same way. Everything is the same. Our approach is just slightly different. So the chances of anybody putting in skeletal traction through the calcaneus in the emergency room or outside of the operating room in this discussion, actually not going to be all that common. So if you want to learn more, we have an educational program we'll talk a little bit more about, and really just look up calcaneal X-fix pin placement.
Beautiful. Yeah, thanks for that, John, because this is something also to everything that he's mentioning. This is something you'll frequently do for your delta frames. You'll be doing it with a centrally threaded pin. So again, knowing your danger structures, just your simple anatomy will always help you performing those procedures. But thanks for that, John.
Sure.
So thinking about, which one do you use? I think a lot of this fundamentally is going to be what is done at your institution. There's a lot of institutional variability that exists. So, especially as interns and as junior residents, kind of understanding the flow and understanding what people are going to expect at fracture conference or whatever is a good place to start. At a higher level, though, I think something nice to think about is where your incision will be. A key thing here is to avoid putting a pin, which is going to be from outside of the body in, near a operative incisional site. So, for example, if you see a low femoral shaft fracture, and you think that it may be going distally into the articular surface, like a true distal femur fracture, you wouldn't want to put a femoral traction pin. You may want to put a tibial traction pin, and that's something, again, especially if you have a senior or something, and you may not know. It's a good question to ask. The question about what you're pulling through, it's a good question. I think that's something I've heard. Again, I don't think there's any literature on this, but frequently these patients have dashboard injuries. They have large fracture dislocations of their acetabulum, And they also have multi-ligament knee injuries, which are really hard to assess in the acute setting because of pain and just general discomfort. So, in those settings, some people have said that, well, it's probably better to pull through the femur because if you have a multi-lig knee injury and you're pulling through the tibia, then the knee could be unstable and you could be putting stress to the neurovascular bundle. I'm not really sure if that's really borne out in the literature, but that being said, that thinking about what you're pulling through is a good option. And then another thing, so is there a reason not to apply traction? Some people may have their preferences just not to do it, from an attending to attending basis. One example that I've seen that it was interesting is, and this is a learning point for interns. If you see a femoral shaft fracture, that's like an obvious fracture to see. Um, Frequently, people will have a ipsilateral non-displaced femoral neck fracture, and that is something you want to make sure you get complete imaging. So you get imaging of the femur, you get imaging of the hip, because if there is an ipsilateral non-displaced femoral neck fracture, that's probably going to be the more important fracture not to displace. You can treat it, with percutaneous screws, especially if it's a young person who you don't want to do an arthroplasty procedure on. So in those cases, if you're trying not to displace something and you're going to be pulling a bunch of traction through the leg, in this case, the femoral neck, it may be good not to apply traction. But again, those are higher level questions. I think that you can bump that up the chain to somebody like me, like a chief resident or an attending or whoever is on call, and just good things kind of in principle to think about. So last thing I'm going to do
The
is talk about.
other thing
Sorry, go ahead.
I can contribute there too. You have to try and think ahead. And yes, I have scoured the literature through skeletal traction, and I have found no reports of anyone applying skeletal traction and causing damage to the neurovascular bundle at the level of the knee because of a multi-lig knee injury that was missed. Haven't found that. Doesn't mean it's not out there, but common sense being common, it makes sense. If somebody has a multi-lig knee, don't hang 15 or 20 pounds through it. That makes good sense. And try and think ahead too. Like Greg was saying, what kind of surgery are they going to need? Where should I avoid? How can I stay away from any operative sites? And the other thing to remember too, when you're choosing is patient habitus. We have some patients who are very large, have very large legs. And even though the pin that we're talking about is 10.5 inches long, the largest size of the cabo usually goes to about 9.5 to 9.75 inches, so almost 10
Mm.
inches. Some patients might have a very large thigh, and even though they have an acetabulum or a vertical shear, we may need to put this into the tibia solely based on skin, soft tissue, size of the leg, positioning of the patient, etc. So there's a lot of things to think about as you're trying to decide where to put this pin.
Yeah, that's a great point. And then if you as a cheat sheet, as a way to cheat it, you can just kind of, if you have that pin in the sterile package, you can hold it over the leg and make sure you have some clearance on both sides, because that's an excellent point, about patient habitus and the cabo actually being a little bit smaller than the length of the pin. So awesome point. So for clinical pearls, I'll give you pearls and pitfalls. I think it goes without saying, especially when you're starting out, you're worried, you're nervous, you're thinking about all the steps, but just remembering that this is like probably the worst or scariest day of a patient's life, and talking to them about it, talking them through the procedure really goes a long way. It kind of sets the stage and it obviously builds your rapport and patient trust. And in these settings, that really can take you a long way. The question earlier about how much lidocaine to use, I mean, using more lidocaine than less, I think is kind of the answer there. And really that 20 cc mark has done me well over the course of residency. And then to John's point, giving it time to actually take effect is obviously a great thing to remember to consider. The third thing is something that, if you have anybody with you, typically your chief will take care of or whatever. But telling the family, hey, look, like, we understand you're here to support, your loved one. However, we're about to do a medical procedure that requires sterility. If you'd please leave the room, we'll bring you right back in after the procedure. Nobody wants to see their son or daughter or grandma or whatever having a pin driven across their leg while they're awake. If anything, it never ends up well. It seems like a barbaric practice, even though it's something that obviously has a lot of literature to support behind it. So asking them to leave the room is a really good thing to do. And knowing your steps. I mean, it goes without saying, always knowing your steps in surgery or any ER procedure is important. It inspires confidence. And in doing so with your chief or whoever is teaching you, it's probably best to do as much as you can outside of the room, and then do a little, shop talk or whatever inside the room, just to, not seem completely unaware of, of all the steps. For pitfalls, I think again we talked about bumping the leg and derotating the leg is only going to help you. Um, and then making sure that you ask for help. So sometimes you do this by yourself, or you're there overnight, and you don't need another doctor to help you do this. You can ask nurses to give you counter pressure as you drive the pin, or to help reposition the leg, etc. So asking for help is always going to be beneficial. And then applying the weight slowly. When you apply these weights, you don't remember that it's not just you're applying weights. The bone is in theory is actually re-lengthening, and you want to give it a little bit of time to do that so that it's not that kind of a jerking reaction. So those are just some of the pitfalls and pearls I have. John, I don't know if you want to add anything there.
No, I think you've touched on everything. Preparation is the key to this procedure. In the end, I promise you, by the time you've done your third one, probably even your second, you're not going to understand what all the hubbub is about. Once you get your hands organized, once you get all your materials organized, the procedure itself is really not that difficult. It's all about preparation.
Perfect. So I know I talked a lot. I'm sorry I do that. Sometimes I'm a little verbose. But if anybody has any questions, obviously put them in the chat. I can stop screen sharing. How do I do that?
No, we still need you to screen share, but I
Oh,
got a
you do?
couple of
Oh,
slides
my
to
bad.
show, and then yeah, and then we go.
Oh, my bad.
Yeah, that's okay.
Well, if there are any questions, John, I think you're going to have to read them, or we can do questions at the end, whatever you prefer.
Sure. No, folks, there's a bunch of people here. Let's ask some questions. What do you got so far? We're going to do a little demonstration here in just a minute, but we wanted to pause for a moment for any questions, comments, interactivity. Who here has done the most pins? Anybody done one?
Probably you, dude.
I saw this really great YouTube video on it. Yeah. I've done a couple, that's for sure. All right. I'm not seeing anything in the chat, so maybe you put everybody to sleep, Greg.
Yeah, I was like, it was either really good or really bad.
They just maybe they feel like they got it.
They got
I got this. Who's
it.
ready to put one in? Let's go find somebody with a broken femur. Can't be that hard.
For the John told me it's for the interns out in Texas. He said he's willing to let you drive a pin across his leg. He's really committed to the cause.
I never did say that. I do have bone models, though. Absolutely, yes. That's you may be misquoting me there, perhaps potentially, but maybe. I'm not saying no. I'm just saying maybe. All right. I'll tell you what. Let's hit your questions in the chat. I'm going to be talking, but we'll move to the demo. Okay. So the skeletal traction procedure kit that Greg had mentioned earlier. What all is included? Here we have a picture of it. This is something that I helped Arbutus Medical put together. So we have the SteriTrack, which is what the name of the pin is, and the SteriGo, which is the drill cover I'm about to show you here in a second. And then in the traction pack, we're going to have sterile towels, Curlex, chlorhexidine, zero form, 4x4s, needles, syringes, a marker for marking your landmarks, a scalpel to make a skin nick if that's something that you like to do as the pin enters and or exits. The only thing we don't have in this kit is the Kirschner bow, the K bow, the tension bow. Those are all the same things, just a different name for the exact same thing. We do not have sterile gloves. Greg had mentioned using your fingers to measure. I can tell you I wear a size 9 glove, and even that's pretty tight. So I have very big hands. I work with very normal sized people, and my 2 finger breadths are very different than most of the rest of the population. So yes, actually measure your fingers. I know that sounds weird, and I'll maybe do that privately, but you do definitely want to know how big that is. It does help you. And it doesn't have the lidocaine. But since we're doing this in a trauma bay, sterile gloves, lidocaine, readily accessible, those should be within an arm's reach or a little farther. The Kirschner bow, we're going to have to go get. We're going to have to get that stocked for now. The next slide there, please.
Sure. And before going through that, so I think John kind of said it at the end. Just if you grab this and you take all your stuff there, I think knowing what this doesn't have is really helpful just to make sure that you're not doing extra steps. So I think he said it right. Sterile gloves, lidocaine, K-bow. Those are going to be important. And then if from a workflow stance, you want to be efficient, you grab those three things, you grab this. Typically, you have bed control or some number to call them early, because you're going to, by the time you're done with the procedure, they very well may be able to bring the bed there. And, it depends how you do your workflow, but I think just calling bed control early, that's the only other thing you have to think about.
Yep, I concur wholeheartedly. So what all is included whenever you have the Arbutus Medical Skeletal Traction Kit? It comes in this fancy dancy blue bag that you see on your screen in front of you. You get the drill, you get a battery that geekily enough has an indicator light on the front of it to tell you how charged it is. And if anyone has been in the OR and had to use a battery that has gone through sterile processing, they know that those batteries will die very quickly and at the exact wrong time. So make sure that you're checking your battery levels so that you're going into a procedure with a full charge, or at least a strong charge. The nice thing I can tell you, I've been using this same drill and same battery, and I haven't charged it in nearly a year. So I'm kind of playing a dangerous game here in front of this webinar, but you know what? I like to take risks. But this thing has lasted a very long time. So these are lithium ion batteries that they don't have to go through heat treatment, so they last a long time. But you can check that before you start. And then you get these fancy dancy little pliers here that do a great job of cutting our 2mm pin. All right. So the next one is the demo.
Perfect. Last thing I'll say is, depending on where your attendings train, like we have some guys from Shock and some guys from Harborview. I noticed the Shock guys could care less if you cut you have pin covers and stuff on this, so it doesn't really matter. But in general, making sure there's no like sharp edges on anything or whatever. If you don't use the pin cover, just make sure you cut the pin tips, because the Harborview guys get really, they really focus on that. So, but if in general, use the pin tip covers to prevent people from getting stuck.
Yeah, I cut mine all the time anyway, just as a precaution. So, all right, I'm just going to move my little laptop here. You get a quick motion sickness. I apologize for that. So there we go. And if you really want to see me even better, there's like a little box there that you can click on to make me full screen. Right next to my name, there's a little triangle. Okay, so what we have here is a simulated femur. We've wrapped this with a little bit of foam just to sort of act like skin and soft tissue. But here what you're looking at is the knee joint. So I'm standing on the medial side. The drill currently is on the lateral side of the leg. And what we're going to do is we're going to open up our SteriTrack, which is our pin, and you can see we have the instructions written across there. So if you need a quick reference, they are in image form, so you don't have to read anything. So it doesn't make it look like you're reading the instructions in front of your patient if you feel like you need a brief recap on what to do. So inside of that box, we're going to have the sterile drape drill cover that's going to make our drill sterile. And we're going to have our pin and pin covers. So we have one pin cover on already, and then we have another one that's sitting off to the side. And this is what Greg was saying earlier, where you can literally take the pin and hold it up. And I mean, obviously this is going to fit this leg, but if you're really trying to see the size of what you need, literally just lay that right on top and it will tell you this doesn't have to remain sterile. So what we're going to do now is we're going to prepare for our procedure just as though we would prepare for any procedure. We're going to say that this is sterile down here, so we're going to open up sterile as we would anything else, and we're going to drop everything on the table just as we would. Nice and easy peasy, get our trash out of the way. And we're going to start by, I'd like to take the pin out, take the pin cover off, get the other pin cover so that they're kind of laying on my tray there and I can grab those easily and set that down. And now we're going to start in with our drape. I'm going to stand you up here just a bit. So now we have the drape open. We see how that's kind of propped open there, and we have our drill laying on its back. This, you don't have to do that, but it does make it a lot easier for sure. And then what we do, we have our sterile gloves on, we'll assume, and we're ready to go. So we set the drill down, drape it over the top, go ahead and pick that up underneath. The camera's not picking up those kind of wings as much as what I would like to show you and what you would see in person. But what you're going to do is drop that down in there, hold that on that side, get your fingers up underneath that, and stand that up as such. Okay, so now this tape is on the outside because we have the adhesive on the outside of the bag. So we pull that tape off, throw that away because we're super cool. We're going to fold that over and roll that up just like that. Now we have our sterile gloves on, sterile drill cover, bag is in the bag, the drill is in the bag, so it remains completely sterile, and we're ready to go. So we can set that back down onto our sterile field, knowing that it won't get contaminated. And now we're going to go ahead and take our pin, and we're going to find our adductor tubercle. It's going to be right here on the medial side. We're going to come 2 centimeters proximal. Now remember, if you have that leg bumped, the femur is going to be on an angle. It's not going to be straight. It's going to be angled. So you're going to have to drop that pin. Don't go 2 centimeters from the top of the leg. You got to go 2 centimeters in line with the bone. So use that thumb. Push, push, push. Find where you're at, okay? We're going to clean, drape, anesthetize like we talked about with the lidocaine. We're going to take our pin. I like to do this freehand rather than putting it in the drill. And I'm going to put it in my insertion point. Okay, I've hit bone. I'm nice and parallel. You can see that through the camera. I'm parallel all the way through. So now we're going to gently go posterior because we need to know that we're centralized in the bone, and we don't. Third time, we're going to throw one more in there. Fourth time, don't want to push this pin posteriorly, or else we're going to find the femoral artery as it transitions into the popliteal artery, and we don't want to be puncturing that. So very gently, we're going to find the posterior aspect of the bone. We're going to kind of note that angle a little bit, just kind of where that is. And now we're going to walk back up the femur, and we're going to find the anterior part, and we're going to see that angle right there. Now, those two angles are about the same, which means we are centrally located inside of the bone. So we're nice and parallel. We're right in the middle of the femur. We have our joint line marked out, so we know we're in line with this. Now you can take and you can either leave the pin in the patient and chuck this, or you can pull it out, pull that pin out and then chuck it. But let's see if you can hear it. 1 second. That clicks into place, and now it's in there. Make sure you're pushing on that blue adapter right there, because that adapter does slide up the bone, or up the pin rather. So we want to make sure that we're not pushing on the pin, that we're pushing on the adapter, and it clicks in. We're going to take this little pin guide. We're going to go right back where we were. Since I came out, I'm going to double check. There's my angle. There's my angle. There we go. Now I'm centrally located. And this pin guide prevents your gloves from wrapping up around the pin. And you can squeeze this. You interns that are starting on Friday on your first one, whenever you're scared, you're squeezing really hard, it's not going to bind your pin up. Don't worry. You can just hold this gently. I like to hold it right in the middle of my pin because we know this pin is going to bend as we push on it, and we're going to counteract that. We're going to focus on this part right here. It doesn't matter if this is bent back here. As long as this part is straight and parallel, we're good to go. So we're going to keep this right in the middle. We're in line with the joint. We're in line with the bed. We're in the center of the bone. Let's go. So we're going to start the drill, pull it back all the way. We're going to apply gentle pressure. We're going to feel it go through the first cortex, through the second cortex. It's out, and we're done. So here we go. Drilling, we're pushing, sliding through, second cortex. We're out. That's it. We take our adapter off. We take our pin cutters. We're going to cut the pin so that the adapter comes off. We're going to cut the other tip so that the part that went through the patient is no longer there should anyone stab themselves. We're going to take our little pin adapters over here. We're going to put that onto the tip so that it protects the patient and everybody else around them, and we're done. That's it. Simple, easy peasy. So that's femoral traction. I'm still watching the chat, everybody. So if you got questions, throw something out there. I'm listening. So now I promised that I would talk about tibial traction. So here's our tibia. Here's the lateral side. You see that little mark right there, okay? So tibial tuberosity, we're going to come distal 2 centimeters. And I say inferior because the patient is laying down like this. So inferior, posterior, laterally, whatever you want. You come toward the toes and go down toward the bed, 2 centimeters each, and you're good to go. What we want to do, if we have this pin and we try and go like this, whenever it spins, it's going to try and walk up the bone. And that's not good. That's not what we want. So what we want to do, we want to come perpendicular, right? That's one of the easiest things that we can do. We need to drill perpendicular to the bone so that we get a good start. What I do is I have this chucked, and assuming this is the patient, I hold it perpendicular, just like this, and all I do is fire the trigger. That's it. Just that little spin. That's going to create that burr. And if we look really closely on the camera, we can see the tip of that pin is now inside of there just with that quick little spin. And now we're ready to go ahead and fire that straight across. No problems. Easy peasy. Nice and straight, in line with everything. But if we take that back out, it's really hard to hold this and do this all together. And we don't go perpendicular. What can happen is, of course, it's not going to do it now, but it's sliding up just a little bit there as we angle down. Go perpendicular, get your burr, shoot that straight across, no problem at all. So that's how we do a femoral pin. That's how we do a tibial pin. Ask me some questions. That's the demonstration that I got for us.
So maybe while we're waiting for people, if you guys have questions, you can put them in the chat, obviously. Couple of things that I think are nice to keep in mind. So, in the OR, a lot of the, OR Power, CD4, System 7, System 8, etc. They have a chuck feature, and people will always tell you, like, don't let the pin bend, don't let the pin bend. I think that's kind of ingrained in our minds, in orthopedics. And I think that's true, the vast majority of the time. This is one case where John's point about using that kind of death grip on the pin and then looking at the actual, looking at the death grip and distal, meaning like to the pin tip, that's the part that you want to make sure is straight. The pin is pliable enough that you're not it's going to be straight once it goes all the way through. So that was something that I remember talking to some of my juniors about, and they were saying, well, it bends, and the answer is it doesn't, but you have to make sure you focus at the right part, because it is a little bit different than some of the stuff you do in the OR. Another thing I just maybe tell people in general is, like, it's kind of like the phrase, like, let the drill do the work. You can put some gentle pressure, but you killing it is what's going to make you skive very easily. So, John was talking about how you make, you kind of make that burr. And in general, like, you can do the one little trigger push like you did. Even if you held it there a little bit longer, but you're not pushing hard, in general, that's what we do in the OR. And I think that's just a really good principle. Like, the drill is powerful enough to do the work. Even on, like, your, NFL, like, whatever, running back who has really, really dense bone, it might take a second longer, but the drill will do the work. So don't just push it really hard.
Yeah, it's kind of hard to explain. So you're absolutely right. You don't want to, like, lean into it. We're not trying to build a deck here, people. We're not trying to put a giant lag screw into a bunch of wood, but we need to put some gentle, even pressure, give that some nice force so that it goes straight across. But yeah, you don't want to be throwing your hips into it. At the same time, this is not threaded, so it's not going to pull itself through. So we don't just want to sit there waiting for it to do something. It's kind of hard to explain. You just need to kind of throw a couple of pins in, get a little practice in. Once you do this 2 or 3 times, you're going to get the feel for it, and it can go right through. But yeah, we want to really focus on that front part of the pin. And yeah, these are 2 millimeter. They're going to bend, and that's just kind of the way that it is. So just focus on that front part that's in front of the drill guide, and you're going to be successful. It's going to be great. Can we, we still don't have any questions in the chat, Greg. Can we
Not
put
yet.
that presentation back up?
Yes, sir. Let's see.
Please.
Share.
This is what happens when you're in charge, man. People ask you to do stuff.
So is this
Okay.
the slide you want?
Yes, sir. So
Cool.
one of the things that I've been working very hard on with Arbutus is a whole training module. So if you want to learn a whole lot more, and you know that you do because you're here on a Wednesday night, so we know that you want to learn more about skeletal traction, you go to arbutusmedical.com and you see our devices as one of the drop downs that's there. And at the bottom is skeletal traction procedures and training. And the next slide there, Greg, will show us what that takes you to. And with that, 3 easy steps. You have to click to register, you sign up, they send you a confirmation email, and boom, you're into the, you don't have to set a password, I don't think, but you do have to register with your email. And what you'll see is a whole training guide. So you get 4 videos that are about 10-ish minutes long of me talking, or you can read through PDFs and all of the different steps. We have the basics of skeletal traction. I take you through femoral skeletal traction, tibial skeletal traction, and very importantly, in my opinion, post-traction care. So what do you have to do after you walk away from the bedside? What is traction doing? What do you want your nurses to look out for? What do you want to look out for? What should the patient expect? What should the patient's family expect? All of that is in there. So I strongly encourage you to go and watch those videos. Like I said, there's 4 of them. They're 10 minutes each, or you can read through if you don't feel like listening to my voice, which is perfectly fine. And really, that should give you a lot of insight into the procedure itself. So that's all I've got. We would love some questions. Is everybody still out there? Like, are you still awake, or do you feel like you've got this and you're just, ready to go do one? That's that's how I'm taking it, Greg. What do you think?
Again, this is when I first started intern year. I it was one of those things that I was like kind of stressed out about just the first time you do it. But I if you guys don't have questions, totally fine. But if there's anything that there's no dumb questions here. It's just trying to kind of walk you through it and get as comfortable as you can with it before you walk into the resus bay.
Absolutely. And the same with any procedure. The more you prepare for it outside of the room, the better it's going to go. And that's true in the emergency room, in the operating room, in the ICU. That's true of putting on a cast or a splint. The more prepared you are walking into this, not only with the knowledge of how to do the procedure, but just having all of your stuff organized, getting your hands organized. That's really what it is. A lot of the great surgeons that we work with, they have their hands organized, and you watch them do something over and over and you think, oh, that's so easy. And then you try and do it and it's like, wow, that's really not, because you don't have your hands organized. You don't have that muscle memory. You don't have the preparation. You don't have everything laid out like you like it, because you don't know what you want or what you need. So practice, even in your head. Watch these videos. You're here now, so that's a good first step. Just pay attention and be prepared, and things will go very well for you. I'm sure you'll be successful. Still no questions in the chat. So lonely.
These guys are just too stoked about intern year.
Absolutely. July 1, we are mere hours away. It's a big day. It's a big day.
July and the 4th of July. Like, if you guys
and the 4th of July, yes.
Out there, be safe with
we do have a question.
Oh.
We do have one question here. Have you drilled through and had improper placement? Not that I'm willing to admit, but yes, absolutely I have. That's a joke. Yes, I have had improper placement. I have had the patient who had excessively hard bone and it was difficult to get through. I've had excessively large legs where it was difficult to get the bow on. I've gone in at the wrong angle. A person at our center a number of years ago went very posterior, and they did not have the leg bumped like Greg was talking about earlier. So they actually went posterior and then lifted the pin up. And doing so, they pinched the femoral artery. and the patient lost vascularity to the leg and ended up in the vascular OR. So that was dramatic. So that's part of why I'm trying to teach this, because that's an unnecessary bad outcome, and I don't want that for anyone. So that's what I'm trying to do. So yes, I've had bad placement. At which point you have to decide, is it not good or is it bad? Because if it's bad, you got to take it out. You cut the pin off on the other side, you pull it back out. You don't pull dirty pin through the bone, and you do another one. You start over. If it's just not your finest work, but it's okay, like maybe it's a little bit off of the joint line, maybe it's a little angled, like it's not perfectly parallel. Okay, yeah, I mean that happens. That's no need to put the patient through a whole second procedure just because you want the style point. So, yeah, Greg, you ever thrown a bad one in?
Yeah, I remember I think the one that, I obviously did this mainly as a junior, but, well, one time I was driving a pin through, and, you always want to remember when you're marching anterior to posterior, that there's a point at which, it's a cylinder, and if you're too anterior, you can be unicortical, and if you're too posterior, you can be unicortical. So I was waiting for the second cortex, which never came. And then you get the lateral, and you see that you have a little, like, cortical pin, and it sucked. It was fine. We
Yeah,
redid it. Um,
yeah,
but that's, and thankfully no dysvascular limbs, so I'll take that as a W.
yeah. I've never had a dysvascular limb. We do have
Second.
another question. How does it
Mhm.
compare to what you used before? So James, I'm assuming you mean the Arbutus Medical Traction system as opposed to what we used before. So I'll go with that. If I'm wrong, type it out. What we used before was an unsterile drill that I had purchased at a home center, and we used just an off-the-shelf straight 2 millimeter trocar tip pin. Um, I think this is far superior. This is FDA approved. So, I mean, I'm glad to be using something that is FDA approved on patients. It is completely sterile. What we would have to do before is you would grab the drill and now you're unsterile. Now you would have to put the pin and chuck the drill, but you couldn't do that one handed and maintain sterility. So you had to have somebody else that would hold the drill chuck for you while you put this in and got that done. And then you had to use an alcohol swab or a bundle of gauze or something to hold on to the pin, because if you just put your gloves on there, it would spin and it would wrap your gloves all up, and there was no undoing that. So it was very easy to make a mistake. It was very easy to contaminate and put the patient at risk for infection. So this system to me is wonderful, and it's much more accessible. It's much more affordable than borrowing OR power, having to run to the OR and grab these things, having to run the sterile process and grab these things, wondering if the batteries are going to work because the batteries have been through heat treatment, and all of those things. This takes a lot of the stress, anxiety, and just running around out of it. Greg, your thoughts?
Yeah, so we actually had a different setup. We used OR power, so we would go get, like a System 7 or whatever, and it obviously worked very well, from like a practicality or from a functional stance. Like the drill was great. I mean, it's what we use in the OR, right? I was comfortable with it. I think the thing that John was talking about the actual pin driver, but the thing that's been really helpful for us is going to the OR when it's 2 o'clock in the morning. You have to go to the core yourself. So you like put a bunny suit on if you're not wearing OR scrubs, or you call the OR and it takes them inevitably 30 minutes to get you the pin driver, the cabo, or whatever. So for us, I think from a maybe an operational standpoint, just kind of just like grab the thing and go and take care of the patient. It was very nice, especially when you're getting like multiple polytraumas or something at once. It's very efficient. Um, and then with that, and similarly in an operational capacity, the skeletal traction procedure kit, you know, it makes you efficient, right? You don't have to go to the Pyxis and then go to the nurse and then do 10 different things. I mean, right? Like now it's simply like grab your skeletal traction procedure kit and your little the little blue bag that John showed. Make sure we have cabos kind of near our workroom, so you grab your cabo and then you go talk to the nurse who already is in recess, has a bunch of lidocaine ready, and and there's sterile gloves there, so it's like operationally way better.
Agreed. Good questions. Mhm. All right. What other questions you got for us, folks? We got a couple minutes left here. Otherwise, I'm going to start telling jokes. I'm not very good at that. So ask something educational. Don't make me use a microphone here. That's yeah. See, that's about as good as I've got, and that's pretty a low bar right there. How many do you think you've put in 4 years, Greg? How many pins do you think you've done?
Like the first 2 years I front loaded because we typically, have like a senior walk the
Sure.
juniors through it. I mean, during those summer months, I would say we were probably like, probably like 4 or 5, a week. So, God, I don't know, but probably my guess is like 40 to 50 at least, probably more, but yeah, more than that actually. Because also some of the things that we do, which we haven't talked about at all here, is in the OR. Some folks actually really like it. They'll
Mhm.
drive a pin in the OR so they can pull traction. And it's an elegant. It works. It's simple. So between the two, probably I don't know, like 70 maybe. I don't know. It's a
No, man.
guess.
Yeah. 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 I figure I've done in the hundreds through the years. And I
Sure. Yeah.
know I've taught thousands because
Totally.
you're talking about the right model where you have the upper levels teaching the juniors. That's how it should be, and somebody like me who's been doing this for decades now. I haven't been in that intern frame of mind, that first day frame of mind in a long time. To me, operationally, this is very easy. So it's good to have people close in your training level teaching you what to do because they remember what mistakes they made 1 or 2 years ago, where as somebody like me who's more senior doesn't. So that's why I would love to see an attending teach an intern how to do this at bedside. That would just be a lot of fun. Because the procedure is not hard, but getting ready is really what it is. That would be fun to watch.
Yeah, and I'll tell you guys, like from if you guys are thinking about questions regardless, but the intern year and especially PGY 2 year when you're taking a lot of these consults, I mean, when you're a med student, you kind of you run to a place just to not really be needed, right? You're like, I'm here, and then you can do some stuff, but not that much stuff. But when you're like a PGY 2 or an intern and you're like really getting a lot of traumas and you realize all these traumas, some of them I'm gonna have to consent, I'm gonna have to mark them, I'm gonna have to do admit orders, I'm gonna have to write my consult note. Like you have all these things to do. So if you can save yourself like 5 minutes of gathering materials, or you can just get your room set up really quickly, or you can actually just finish the skeletal traction procedure on one patient and move to the next. That's what makes like your night and your flow just work. What really hurts you is when you go reduce somebody's radius and then you come back and the traction bed's not there, and then you say, oh crap, well I guess I got to go do something else, and then you forget to do something, and then lo and behold it's 5 o'clock in the morning and you're running to a fracture conference and your chief is texting you. So like trying to be like really efficient with your time and really organized is going to help you no matter what, and this system does both of those things for you. So just get comfortable with that, and I think it'll really serve you well as a junior.
I agree. Getting yourself ready, keeping yourself in that flow, keeping yourself organized, task completion, being prepared, all of these things make the procedure so much smoother, make your day so much smoother, makes everybody more happy, including you. Well, I say if we don't have any more questions, we call it an evening. What do you think, Greg?
Yeah, totally. Thank you guys for joining, and congratulations on making it. You guys are interns now. You guys are doctors. Go save some lives, save some limbs.
That's right. That's right. Go drill some holes in some bones. It's going to be great. All right. Well, thank you, everybody.
Thank you guys. I guess I'm just gonna end it. See you, John.
Yeah, just end it. See you later. Thanks, Greg.